Can everybody hear me? I apologize for being late, guys. We were having a little bit of technical difficulties. But we'll go ahead and get started. My name is Farook. I'm one of the PGY5 EM/IM Critical Care Fellows, and I will be talking to you guys about ICU management of neuromuscular diseases. In particular, we'll be focusing on myasthenia crisis and Guillain-Barre. So understanding myasthenia gravis, just to recap, it's an autoimmune disease of the neuromuscular junction of skeletal muscle caused by antibodies against components of the postsynaptic membrane. The most common component of the postsynaptic membrane targeted in myasthenia gravis is, of course, anticholinergic receptors. This is present in about 80% of myasthenia gravis, but other forms do exist, and they involve antibodies against muscle-specific tyrosine kinase, or LRP4. Myasthenia crisis is an acute exacerbation of myasthenia gravis, predominantly affecting the bulbar or respiratory muscles, leading to neuromuscular respiratory failure and the need for ventilator support. And looking at the pathophysiology in myasthenia gravis, if we look to the right side of the picture, what we see is that the antibody attaches to the acetylcholine receptor, and that leads to a receptor delay and internalization, activating the complement system and ultimately leading to impaired signal transduction and muscle fatigue. Precipitants of myasthenia crisis, infection is the #1 cause, pneumonia being the most common infection that can exacerbate myasthenia gravis. There are certain medications that are notorious for worsening myasthenia as well. We all know about fluoroquinolones being contraindicated, as well as macrolides. Ampicillin has also been implicated in some case reports. And there are some antihypertensive that we have to be judicious with in myasthenia patients. These are not absolute contraindications, but these are something to be careful with. Beta blockers can destabilize the acetylcholine receptor clusters, and calcium channel blockers work by reducing presynaptic release of acetylcholine. And of course, pregnancy can worsen myasthenia gravis as well as surgery. So understanding the precipitants for myasthenia crisis, we must follow this with a solid ground on recognizing myasthenia crisis. So there are both clinical and objective findings that we should be familiar with. With clinical signs, most of these aren't new. It will be concerning for any patient if they're having increasing shortness of breath at rest, if they're having difficulty swallowing, protecting their airway, using accessory muscles. Some of these we are familiar with. But there are some that I want to highlight, especially in the context of your myasthenia patients. When they're short of breath when supine, this is a very distinct clinical finding. Because as they get closer to crisis, they will naturally start to depend more on their diaphragmatic function through gravity. And sometimes they will even complain that they can't breathe when they're laying flat, and they will insist on sitting up or resting at an incline. Slurred speech and hypophonia, or a weak voice, trouble swallowing, these are all constellation of symptoms related to bulbar weakness. And bulbar weakness can be the predominant feature of some myasthenia patients. And of course, development of accessory muscle use is particularly concerning for myasthenia patients because they will fatigue faster and they can sometimes become completely apneic. On the objective side, some of these, of course, end-tidal CO2 would be a great rudimentary non-invasive tool for assessing ventilatory status in myasthenia patients. Ivig for a more accurate PCO2 status, so that will be more of a point of care type of picture. And then there's this 20-30-40 rule that I've come across during my research that can help sometimes with guiding you on deciding intubation. So we talk about a vital cap less than 20 has been associated with an ineffective cough, poor handling of secretions, atelectasis, and hypoxemia. An inspiratory pressure greater than -30. So if they're like -20 or -10, it would signal you to catch their weakness of their inspiratory muscles and their diaphragm. And the max expiratory pressure of less than 40 can involve your expiratory muscle function, and that can be closely linked with your ability to cough and clear your secretions. But I put in a caveat at the bottom of the slide that we will never make a decision on intubation if your objective numbers can look somewhat reassuring, because we always have to come back to our clinical signs and symptoms. And it's much safer to opt for elective intubation in myasthenia crisis. This is because some of these numbers, like the 20, 30, 40 rule, the determinations rely on multiple factors. First of all, it has to rely on your patient's effort. It requires proper closure of the mouth. So muscle weakness can sometimes fluctuate in these patients. They can develop sudden onset apnea or precipitously fatigue with rapid respiratory failure before you can start to notice a downward trend in their numbers. And the other thing to keep in mind is that none of these numbers have been validated through prospective studies, especially in myasthenia patients. They have been studied in a few other neuromuscular diseases. So these values are basically borrowed. So we want to avoid becoming falsely reassured if a patient doesn't show accessory muscle use, or maybe if they're pulling a NIF of -30 or -40, because none of them have been truly been shown to be a reliable predictor on the need for mechanical support. They should always be interpreted in the context of your clinical symptoms and signs. So now that you've made a decision on your patient requiring positive pressure ventilation, so do you pick non-invasive or do you go straight to endotracheal intubation? The answer is that it depends. Of course, if your patient is worsening, on the verge of becoming apneic, they're unable to handle their secretions, they have severe bulbar weakness, they have confirmed aspiration, then of course, intubation, you have more than enough evidence to push for intubation. However, if we can recognize myasthenia crisis early, then maybe there's a role for non-invasive positive pressure ventilation. Now, keep in mind, we don't have any randomized controlled trials that assess this. All we have are some case series and retrospective studies. Now, the earliest one that I found was a case series of 9 patients that was published by Ravenstein and his colleague. And they treated myasthenic crisis patients with non-invasive positive pressure ventilation. And they reported a few interesting data when it came to their outcomes. They saw that length of stay was significantly reduced. And they also determined that the marker of an arterial PCO2 of greater than 50 could potentially predict BiPAP failure. Now, of course, this is a case series. So aside from the inherent limitations of that type of study, there's other reservations to consider. Number one, there have been some that argued that the inspiratory pressures that were used for BiPAP was not high enough for some of the patients. So this determination of the PCO2 of greater than 50 leading to BiPAP failure may have been because they used low inspiratory pressures. And number two, crisis patients usually require only ventilatory support. And some of the patients had much higher oxygen requirements. So their inherent problem was not just the myasthenia, there was also an additional lung injury. So that could also confound some of the results that they reported. And this was a second study. This was a retrospective study of 60 patients who are also in myasthenic crisis. Out of the 60, 24 of them were trialed on BiPAP. And out of the 24, 14 of them ended up not requiring any invasive ventilation. There were no baseline differences or respiratory variables or ABGs between the groups. And they also found that the length of ventilatory support days were significantly lower in the patients who did receive BiPAP. And their ICU and hospital length of stay were also decreased by about a third. The rates of pulmonary complications didn't have any differences. And they did also find a level of PaCO2 greater than 45 being associated with BiPAP failure. And again, this was a retrospective study. And it's not entirely clear from this study on how they selected the patients to receive BiPAP versus early intubation. Did those patients have intact facial and neck muscles? Did they have intact swallow function? All of those things. And the decision may have been a combination of factors, including the underlying precipitant for the myasthenic crisis. Was it infection? Were there other medical complications? Was it based on their vital cap or their NIF scores? So nonetheless, these are all pretty small studies, and we still are lacking prospective data. But maybe there's enough evidence to suggest that there is a role for non-invasive ventilation for myasthenic patients. And maybe it could be beneficial, but again, we need more prospective studies to solidify this benefit. So you've intubated your patient. Now what do you do? So there's a caveat I want to highlight, and it's that in myasthenic patients, we try to avoid depolarizing paralytics, especially succinylcholine. Well, why is that? And the reason for that comes down to our physiology. Depolarizing agents, they work in the acetylcholine receptor site, like at the very same site as the acetylcholine. So this ultimately depends on the functional status of the receptors. And in myasthenia gravis patients, some of the receptors do not act normally. So you may end up requiring higher amounts of the depolarizing agent to overcome that resistance. Non-depolarizing agents, on the other hand, like rocuronium, it acts as a competitive inhibitor of the acetylcholine receptor. And since you have less normal receptors, it makes it more sensitive to non-depolarizing competitive agents. And there have been some case studies that showed that you need lower doses of non-depolarizing agents for paralysis, even less than 50% of your typical dose. And most of the guidelines will tell you that you should anticipate longer duration of paralysis. And this is for both depolarizing and non-depolarizing agents. All guidelines that I looked up dictated that acetylcholinesterase inhibitors should be discontinued once the patient is intubated and relying fully on positive pressure ventilation. The reason for this is because acetylcholinesterase inhibitors primarily provide symptomatic relief. They do not alter the course of the crisis itself. They can also confound your assessment of any improvement in their muscular weakness. And the other side effect profile to be aware of with acetylcholinesterase inhibitors is that it can cause bronchial secretions. So in a patient in respiratory failure, they prefer to avoid it. And so this brings us to our second point, pulmonary toileting. Myasthenia crisis patients will almost always have an ineffective or a weak cough and poor airway clearance. There were two retrospective studies that identified atelectasis as an important predictor of reintubation in myasthenia crisis patients. Therefore, aggressive PT, humidification of inspired gas, and suctioning of your oral secretions should be initiated early. And the last point to make is that for ventilator settings, a lot of guidelines kept highlighting 8 to 10 cc's of tidal, 8 to 10 cc's per kg for tidal volume and a higher peak. And the reason for this is purely to prevent atelectasis and to reduce the work of breathing as much as possible. This is not evidence-based. This is purely on expert consensus. And of course, this management with the higher tidal volume and higher PEEP is contingent on your peak pressures remaining under control. And so that means you have to make sure there's no other underlying lung pathology like ARDS. But if there is, then you obviously need to adopt a more lung protective strategy. So treatment modalities, what do we treat our myasthenia crisis patients with? The two main ones are plasma exchange and IVIG. Historically, plasma exchange has been the standard for immunomodulation in myasthenia patients, but its efficacy had never been investigated in randomized controlled trials. It became more of a time-tested standard because of the way it worked. It worked by removing the antibodies responsible for your myasthenia symptoms. IVIG, on the other hand, affects all components of your immune regulatory network. It suppresses your antibody production, it interferes with complement activation, it modulates the expression and the function of your FC receptors, it alters the function of your T cells. So this might be a reason why there's a more rapid response seen with plasma exchange as compared to IVIG. And this shorter time to response with plasma exchange has been documented in some small studies. But nonetheless, we are going to take a look at some of the cited literature available to us between the two treatment groups, treatment modalities. So the first one is comparison of plasma exchange and high dose intravenous immunoglobulin in myasthenia gravis. This was a study that randomized 87 patients to either to 3 different arms. It was IVIG for 3 days versus 5 days versus plasma exchange. And their primary endpoint was the myasthenia muscular score variation at day 15. And what they found was that there was similar variation between all the groups, but there were some pretty significant limitations with this study. The MSS assessment ended up being unmasked towards the later parts of the trial. So this could have led to a bias towards any of the treatment group. And some of the patients in the plasma exchange group also did not finish their full course. So that could also confound the results for a true benefit with plasma exchange. The next study is comparing IVIG and plasma exchange in patients again with myasthenia crisis. They randomized 84 patients with moderate to severe myasthenia to IVIG over 2 days versus plasma exchange. They looked at QMGS score at day 14, and the QMGS score stands for quantitative myasthenia gravis score. It is a validated 13-item scale, and it compares clinical, electrophysiological, and lab markers to assess disease severity in sentinel muscle groups, and it's considered the gold standard for myasthenia gravis studies. And a change in the QMGS of around 3.5 units out of 39 is considered clinically meaningful. So primary endpoint, like I said, they looked for a change in the QMGS score at day 14, and secondary endpoints, they continue to follow the patients at days 21, 28, and 60. They also looked at single fiber EMG and repetitive nerve studies. And they also looked at whether they had a need for ICU admission, any use of positive pressure ventilation, or any hospitalization. And what they found was that there were no differences between any of the groups. Neither group required hospitalization after 2 weeks. They did see a reduction in the repetitive nerve study in both groups, but they noticed that the positive effects from plasma exchange ran out by the time they hit day 28 when compared to IVIG. Again, the main limitation with this was that all of this was done outpatient. None of these patients were in crisis at the time of starting this treatment. So that would obviously confound, we would obviously have to take this study with a grain of salt when we're assessing our crisis patients. Now, steroids were historically the first medications to be used in the treatment of myasthenia gravis. Therefore, they have remained in use even for patients in crisis. Now, part of the reason for its use in crisis is also because, like we talked about earlier in the last slide, the effects of IVIG and Plex will wear off, and usually it's around the time of weeks 3 to 6. So on the other hand, there was a case series from 1984 that showed that for steroids, the mean time to your desired effect was around 13 days. And about 85% of your patients showed improvement within 3 weeks. So the recommendation is that you start it simultaneously with your IVIG and Plex. And since they take roughly 2 weeks to kick in anyway, then you basically continue it and hopefully it'll prolong the desired effects of your patient's clinical improvement. But then again, if for any reason steroids were not started and you already notice a rapid improvement in your patient's recovery, you may consider holding off on the steroids. Another conditional aspect, like I mentioned in the last line of the slide, is that steroid may cause an initial worsening in symptoms. And the pathophysiology behind this isn't entirely clear, but there's a theory that says that there's an initial lymphocyte degradation that could lead to an increased release of your antibodies. So it could lead to a paradoxical worsening. But after the first few weeks of treatment, then the immunosuppressive effect could start to work and it'll help improve your symptoms. So when we use them in crisis patients, the guidelines dictate not to stop steroids, but rather to continue your ventilatory support and maintain the steroid dose. And once you start to notice significant improvement, then you can start tapering down on the prednisone. Again, I want to highlight that there are no randomized control trials that demonstrated a true efficacy with steroids in myasthenia gravis, let alone in crisis. Most of the information I provided on this slide was derived from guidelines that were largely based on the case series that I mentioned from 1984, where they studied just 116 patients, and those patients range from age of 8 to 82. So, of course, now once we reach a point of clinical improvement, we have to assess readiness for extubation. And when we care for myasthenia crisis patients, we have to note that they are unfortunately at a higher risk for both prolonged intubation and re-intubation. Half of our patients are extubated before day 14, but that also means the other half will stay intubated. And re-intubation can occur in up to a quarter of the cases. So these numbers, to be fair, are identified through retrospective studies. Nevertheless, these are statistics that we need to keep in mind, and we need methods of assessing how soon or how effectively can we extubate our crisis patients and reduce their risk of complications. Some of the risk factors to be familiar with: age greater than 50, concurrent pneumonia, Apache 2 score greater than 6, presence of atelectasis. They're all associated with extubation failure and prolonged intubation. Again, coming back to our clinical assessment, some of the same indicators that we would use to decide whether or not a patient needs mechanical support, it can also help you with deciding whether or not a patient can be weaned from the ventilator. We always want to ensure adequate pulmonary toileting and their level of secretions. The 20-30-40 rule, again, you can utilize it here. And if they're on a ventilator, you may obtain more accurate data on these. Your respiratory therapist can help you a lot. Most importantly, there was a retrospective study done in 2009, and it found that the max expiratory pressure of greater than 40 was an independent predictor of both cough strength as well as extubation success. Outside of this one retrospective study, there were 2 other studies, but they were done in other neuromuscular diseases. And they also identified a max expiratory pressure of 40 to 45 as the cutoff to determine cough efficiency and potentially indicating crisis. So if they're intubated, there should be a daily assessment of their vital cap, their expiratory pressure, their NIF, in addition to observing their cough strength and improvement in their facial and neck muscles. So summarizing our myasthenia crisis management, early recognition is key. Non-invasive positive pressure ventilation may be used. It has the potential to reduce ventilator days and length of stay. IVIG and plasma exchange have similar efficacy and should be initiated as soon as possible, as soon as mechanical support is introduced. Clinical and objective evaluation should be performed daily to track the progress of your myasthenia crisis patients. And of course, we need more randomized controlled trials to investigate effective therapies and ventilatory management. All right, we're done with myasthenia. You guys need a break? All right, Guillain-Barre. We define it as an acute form of immune-mediated paralytic peripheral polyneuropathy. Say that 5 times fast. It's an acute flaccid paralysis, may or may not have sensory and autonomic nerve dysfunction. There are several subtypes of Guillain-Barre, and we often see the terms AIDP, AMAN, AMSAN that are used. The prototypical version of Guillain-Barre that we are familiar with is the acute inflammatory demyelinating polyneuropathy. But there are other axonal variants, like the acute motor axonal neuropathy, as well as acute motor sensory axonal neuropathy. And the AMAN and AMSAN are pretty self-explanatory in terms of what symptoms they can cause. Usually, so the International Guillain-Barre Syndrome Outcome Study determined that about 3/4 of the patients will report some sort of triggering event in 4 weeks prior to their Guillain-Barre diagnosis. So usually there's some sort of antecedent event. Patients will describe either an upper respiratory tract infection or a GI infection. We usually learn about Guillain-Barre in medical school in the context of Campylobacter infection, because that is the most common etiology of Guillain-Barre, but there have been other infections that have been implicated in Guillain-Barre, and there have been case reports that identified H-flu, CMV, mycoplasma, flu A and B, as well as COVID in the development of Guillain-Barre. Other diseases that may also that have been linked with it are lupus, sarcoid, Hodgkin's lymphoma, and there are some medications that have also been reported as potentially precipitating Guillain-Barre, including our lovely Prograf and TNF-alpha inhibitors and such. Pathophysiology, Guillain-Barre can be triggered by a cross-reaction of your immune system to some other antecedent infection or event, in which you have to have shared epitopes on our peripheral nerves. And this is what we identify as molecular mimicry. Our antibodies react with these epitopes and trigger a hyperreactive immune response and a subsequent cytokine storm. And in the case of Campylobacter infection, we've been able to identify several antibodies in the pathogenesis of Guillain-Barre. Some of which I've listed. There's anti-GM1, GM2, GD1A, and etc. One of these, the GQ1B ganglioside, is expressed in the oculomotor nerve. And so those antibodies have frequently been, they've been found in variants of Guillain-Barre causing ophthalmoplegia. Antibodies against the GM2 ganglioside have been identified in CMV-induced Guillain-Barre, causing severe motor and sensory deficits. There is a variant known as Miller-Fisher syndrome, and it's characterized by ophthalmoplegia, areflexia, and ataxia. This occurs in roughly 5 to 10% of Guillain-Barre cases, and about 85 to 95% of Miller-Fisher of cases with Miller-Fisher will have autoantibodies against GQ1B. The Nines Institute had published a diagnostic criteria back in 1978, and this is what's been widely used in clinical practice. There have been a few updates over the last few decades to reflect the advances on our understanding of Guillain-Barre, but for the most part, it's held up. There was an epidemiological study done in Italy in 1999 that showed that about 84% of patients with Guillain-Barre fulfilled the Nines criteria, and the other 16% had a variant syndrome. So required features of Guillain-Barre includes a progressive muscle weakness. The muscle weakness can vary from mild difficulty with walking to near complete paralysis. It can be paralysis of all extremities, facial muscle weakness, respiratory, or bulbar muscles. And the progression, now this is where we come to the suggestive features of it. The progression of symptoms will typically be days to weeks, symmetric or bilateral symptoms, cranial nerve involvement, the cerebrospinal fluid with elevated protein and normal leukocyte count. This is what we understand as albuminocytologic dissociation. I placed an asterisk next to it because this protein elevation varies by the time since symptom onset. So it may be present in 50 to 60% of 50 to 60% of patients that present within the first week of symptoms, but more than 75% will have it by the third week. So that also means that anywhere from a third of your patients to half will have a normal CSF because you tested them too early. So if you happen to do the LP at the time of admission or within the first few days of symptoms, you may have to end up repeating the LP if the first one was normal. With the electrodiagnostic studies, you can do nerve conduction studies like or EMG, and the same condition applies. Early in the disease process, you may have normal findings. And in the ICU, sedation can interfere with some of these studies. Nonetheless, it doesn't mean that you can't do them if they're sedated, but it may be helpful to continue monitoring them with serial tests to assess for recovery. Other diagnostic tests. So when your LP or your EMG studies are not confirmatory for Guillain-Barre, then you can potentially send for antibody testing or and advanced neuroimaging. The reason for pursuing further testing in these patients is to also rule out other causes of myelopathy, such as transverse myelitis, Lyme disease, porphyria, paraneoplastic syndromes, or even just an inherent spinal cord issue rather than an immunologic issue. An MRI of the brain plus the entire spine is often done based on the extent of your muscle involvement. MRI might reveal thickening and enhancement of the spinal nerve roots or in the cauda equina. Even in brain MRI, you may see enhancements of the oculomotor, abducens, and facial nerves. And these are all suggestive features of Guillain-Barre. So to understand how to monitor patients with Guillain-Barre, we should have a rudimentary understanding of its timeline to disease progression. So typically, Guillain-Barre evolves to a nadir within 4 weeks before it starts to improve. There was a retrospective series done in 1991, and they presented that nearly 75% of patients had continued progression for up to 2 weeks, followed by a plateau phase between weeks 2 and 4, and then recovery of function. With this said, up to 30% of your patients with Guillain-Barre will develop respiratory dysfunction requiring mechanical support. So the other thing is recall that Guillain-Barre also causes severe autonomic dysfunction, and that can require continuous monitoring. So ICU level of care may just be necessary for monitoring purposes, neurologic checks, and frequency of medical interventions. So we come back to trying to recognize the need for mechanical support in our patients with Guillain-Barre. A lot of these are pretty much the same as the ones I had up for myasthenia. Again, any sign of bulbar dysfunction, trouble swallowing, inability to clear secretions, these should be concerning for impending respiratory failure. And the only one that I think on the clinical side that I added for Guillain-Barre is dysautonomia. Dysautonomia is significantly associated with an increased risk of requiring mechanical support. These are symptoms because it causes demyelination of your afferent nerves of your autonomic nervous system. You can have life-threatening bradycar tachyarrhythmias, cardiac arrest, fluctuating blood pressures. So sometimes just for that reason, they will need ICU level of care. If we look at the objective criteria, Also, again, largely unchanged from the myasthenia patients. And again, we come back to this 20, 30, 40 rule. These numbers, again, they're not prospectively validated. They've been derived from data from observational and retrospective series in Guillain-Barre patients. There was a retrospective study that was published back in 2001. They collected data from 114 Guillain-Barre patients, all of them admitted to the ICU. And the primary outcome that they tried to determine early markers that can predict respiratory failure and requirement for mechanical ventilation. And so they noticed that a vital cap less than 20 cc's per kg at any point during the hospitalization independently predicted need for intubation. Inspiratory pressure greater than 30 and expiratory pressure less than 40 were both significantly associated with progression to respiratory failure. Again, like I said, it needs more prospective data for validity, but it can provide us with some objective data to at least move patients into the ICU. And maybe even will help you avoid a more urgent intubation under suboptimal circumstances. So I wanted to discuss the role of non-invasive positive pressure ventilation in Guillain-Barre in the fact that there is none. Guidelines regarding respiratory failure for Guillain-Barre, they largely recommend against using non-invasive positive pressure ventilation. There was one case report published in 2006 that said that their BiPAP could lead to more rapid respiratory failure. But there is a study that I'm going to discuss in the next slide where they did in fact use non-invasive ventilation in some of their patients. So this was a randomized trial looking at early mechanical ventilation in patients with Guillain-Barre syndrome. And the outcome that they were looking at was whether or not early mechanical ventilation reduced the incidence of ventilator-associated pneumonia, because it is a common complication of Guillain-Barre patients who end up intubated. The incidence is around 75%. So the thought process they had was that maybe delayed intubation increased this risk. They included, their inclusion criteria included patients who had to present within 7 days of their symptoms, inability to lift their head, their vital cap had to be less than 60% of predicted. They did exclude patients who had obvious signs of impending respiratory failure, because if they presented with impending respiratory failure, they couldn't be randomized. So they excluded those patients that presented automatically from that. And of course, if you had hemodynamic instability, dysautonomia, they were also excluded. The experimental arm would get either non-invasive ventilation, BiPAP, or they would get intubated. But they made that decision based on the absence or presence of swallow dysfunction. The conventional arm, on the other hand, they would only receive chest PT and oxygen face mask only if needed. And they were not allowed to get any mechanical ventilation unless they met the criteria for respiratory distress. So that was like if their PCO2 was going up, their PO2 was low, their vital cap was less than 20%. And the primary outcome that they looked at was, of course, like I mentioned, the incidence of ventilator-associated pneumonia up to ICU discharge or 90 days, whichever one came first, and a few other secondary outcomes like time to onset of pneumonia, time on mechanical ventilation, length of stay, trach requirements, etc. So what they found was 25 patients in each arm. Out of the 25 patients in the experimental arm, 14 had started off with non-invasive ventilation, but 6 of those had to end up being intubated. So in total, 17 out of the 25 ended up on invasive ventilation. Now, in the control arm, everyone was intubated. No one had non-invasive ventilation. For the primary outcome, they noticed there were no differences. And even in secondary outcomes, there weren't any differences between the two groups. Now, that's great and all. So basically, they determined that early mechanical ventilation didn't really reduce the incidence of ventilator-associated pneumonia, and it also did not prolong length of stay in the hospital or any other adverse events. Limitations being this was single center, limited generalizability. Treatment teams couldn't be blinded because if you were intubated, or you were on BiPAP, like you could see it. So I brought this study to our attention because they very obviously use non-invasive ventilation, even though all the guidelines say that you shouldn't use it. So the authors addressed this in their discussion, and their argument was that even though that there was a case report back from 2006 that everybody keeps citing that suggested that BiPAP may lead to more rapid respiratory failure, it's been shown to be beneficial in other neuromuscular diseases. So if patients were randomized to the early mechanical ventilation arm, but they had intact swallow function and they were protecting their airway, they felt that morally and ethically it was incorrect to automatically intubate those patients and expose them to added complications related to mechanical ventilation. So just something to understand that maybe there are certain people that could benefit from non-invasive, but we don't have enough evidence for it. Treatment modalities, it's the same thing, plasma exchange and IVIG. Historically, because of the pathophysiology of Guillain-Barre, plasma exchange has been the main treatment, and it has been validated as an effective therapy in Guillain-Barre. Most of the clinical trials were done back in the 1980s. But later on, we discovered that IVIG resulted in improvement in other immune-mediated disease processes, and so it's become more readily available in hospitals, and it had a better side effect profile. And it was later studied in randomized controlled trials and determined to be just as efficacious. But there were some trials that suggested that maybe IVIG was slightly superior to plasma exchange, and that maybe it led to a faster recovery. But none of these studies were powered for superiority. So to resolve this, there was an international multi-center trial done back in 1997, and it was published in Lancet. They randomized 379 patients to either IVIG for 5 days or plasma exchange followed by IVIG. All the patients were treated within 2 weeks of their symptom onset, and they were followed for 48 weeks. They used an intention to treat analysis, and the primary outcome was they used the Guillain-Barre disability score. It was previously known as a 7-point functional score, and each number is graded in terms of your symptoms, 0 being no symptoms, 1 being very minor symptoms, but you're capable of running, 2, you're able to walk 10 meters, but you can't run, 3, you can walk with assistance, 4, you're bedridden, 5, you're on mechanical ventilation, and 6, you're dead. And this score was gathered by a blinded observer. Obviously, none of the patients had a score of 6, by the way. I just want to put that out there. This trial basically demonstrated that there were no significant differences among any of the 3 groups, whether in primary or secondary outcomes. So it did put to rest some of the belief that IVIG was better than plasma exchange or that it was more advantageous. But it did have some limitations. Like I said, some of the patients, they had varying degrees of Guillain-Barre. Not all of them were intubated or required ICU level of care. But despite this, it was still helpful in showing that there was similar efficacy between both IVIG and plasma exchange. Following up on the discussion for therapeutic options for Guillain-Barre, this trial observed the role of steroids and the potential for any added benefit when combined with IVIG. Now, this was a very important trial because this more accurately represents current practice, because now you will give your patients either IVIG or a plasma exchange. You will never treat Guillain-Barre with just steroids. So they tested patients who specifically got IVIG plus steroids. They randomized 225 patients, and they randomized them to either IVIG with placebo or IVIG with steroids. They only enrolled those patients who could not walk independently and started treatment within 14 days of weakness onset. So that means that they had a functional score of at least 3 or greater. They compared the two treatment groups at 4 weeks, and they noticed that there were no significant differences between the group. So this demonstrated that steroids had a very limited role or no role at all for the treatment of Guillain-Barre. And current guidelines also do not routinely recommend using steroids for Guillain-Barre. So when assessing how soon patients can be extubated, if they are requiring mechanical ventilation, it is important to have an understanding of the natural history of Guillain-Barre. Recall that I mentioned earlier that the nadir of Guillain-Barre occurs roughly around 4 weeks. But ultimately, the decision to extubate your patient will depend on their clinical improvement. Therefore, we again come back to evaluating our clinical and objective markers. So aside from regular spontaneous breathing trials, we should also assess for improvement in their muscle strength, especially those involving facial and neck muscles. Cough strength and ability to clear secretions are also very important factors. And like I said, if they're intubated, they should be having daily assessments of their vital cap, their inspiratory pressure or expiratory pressure, in addition to observing for improvement in their facial and neck muscles. In summary, again, early recognition is key. Non-invasive positive pressure in the setting of Guillain-Barre has very limited role. IVIG and plasma exchange both have similar efficacy, and steroids may be ineffective. And again, clinical and objective evaluations should be performed daily in tracking the improvement for your Guillain-Barre patients. And that is all. Do you have any questions? Awesome. Thanks, guys. My thing only said, it only says Girl, it's like 50 minutes, girl. You want more?
Yeah. I don't know who's logged in. Oh, somebody logged out now. You want to log in?
Yeah.
Okay.
I was supposed to be in charge at first, so that's why I was like,
Oh, yeah.
but if you're here,
No,
no,
you're-
no, dude, no, you're totally fine, you're totally fine, no, no.
I can't steal your. Somebody's idea. Yeah.
For years.
Thank you.
Do I have to download it and then open it up in PowerPoint? Wait, when I open it up from the email, it just opens it up in like not in Microsoft PowerPoint. All right. I just download it to the desktop.
No worries.
Oh yeah, do we have any after this?
If you're on a rotation that you need to, then yes.
No, Dr. Rivers let me go.
Okay,
He
good.
was like, I'll take care of afternoon rounds. I was like, ah.
Oh, sick leave.
Pregnancy-related respiratory physiology. Most of physiology. I try.
I remember your last one was really quite. What did you do again?
ABPA, yeah.
Yeah, I remember it. It was fun.
It's not the most like arousing topic, you know, like, oh my gosh, I'm so interested to learn about pregnancy-related pulmonary physiology.
Pathological process. Yeah, we did this. I'll never forget that. That was like the first thing they taught us. They were like, don't let anybody tell you that this is pathological. Like, yeah.
Duly noted. That's like a parasitic infection or something. Yeah.
He went up and was like, who else do you know that plasma volume increases by this much, but it's normal? Like, it's just pathological.
Do you think, man? That's rating actually.